Hello, everyone, and welcome to my TED Talk for NURS 524 on osteoporosis. My name is Jacob Knudzik-Partita, and I'm excited to talk with you all today. We will discuss pathophysiology, risk factors, assessment, and treatment for osteoporosis. Many of us working in the Great White North have probably cared for many patients, typically older adults, with skeletal fractures due to falls. While mechanical fractures can happen for many reasons, living where the streets turn into a skating rink doesn't help with fall prevention. According to McCants and Huther, osteoporosis affects 52 million people in the United States. We might have a relatively superficial understanding of osteoporosis, knowing that osteoporosis means individuals have low bone density, predisposing them to fractures that wouldn't otherwise occur in most individuals. The pathophysiology surrounding osteoporosis is much more complex, so join me in learning about osteoporosis. Osteoporosis, or porous bone, is the most common bone disease. This disease is characterized by low bone mineral density, impaired structural integrity of the bone, decreased bone strength, and the risk of fracture. Patients can have primary, also known as idiopathic osteoporosis, or secondary osteoporosis. Primary osteoporosis is the most common. Secondary osteoporosis is caused by other conditions including endocrine diseases that cause hormone imbalances, diabetes, hyperparathyroidism, hyperthyroidism, and it can also be caused by medication such as heparin, corticosteroids, phenytoin, barbiturates, and lithium. Other substances like tobacco and alcohol can contribute to secondary osteoporosis. Some diseases like rheumatoid disease, HIV, malignancies, malabsorption syndromes, and liver or kidney disease increase the risk for osteoporosis. Additionally, postmenopausal osteoporosis and regional osteoporosis can be concerns. Postmenopausal osteoporosis occurs in middle-aged and older women and occurs due to estrogen deficiency, as well as estrogen-independent age-related mechanisms. Regional osteoporosis is described as osteoporosis that is confined to a region or segment of the appendicular skeleton and is characterized by bone marrow edema and can cause severe pain. This typically occurs in pregnant patients and in the lower extremities. Luckily, this form is usually self-limiting. Osteoporosis can be defined based on bone mass described by the World Health Organization as bone mass less than 648 milligrams per centimeter squared. Usually, bone mass is more than 833 milligrams per centimeter squared, and from 648 to 833 describes osteopenia. We can also obtain T-scores from DEXA scans. Osteoporosis is diagnosed when bone density is 2.5 standard deviations below average. This disease occurs when bone reabsorption and bone formation are disrupted, reabsorbing old bone faster than the new bone, making the area porous and the matrix weak. Hormonal influences are essential in maintaining bone health, and genetic factors and the role of oxidative stress are becoming more critical in the study of bone homeostasis. PTH plays a significant role in osteoporosis and bone health. If calcium and phosphorus levels are low, PTH stimulates the osteoclast to resorb bone. The mechanism releases calcium and phosphorus from the bone into the bloodstream. Reactive oxygen species are becoming prominent players in the study of the development of osteoporosis. Accumulation of reactive oxygen species and oxidative stress can result in loss of bone mass and strength. These reactive oxygen species serve as signaling molecules like osteocytes, osteoblasts, and osteoclasts. Hormones, cytokines, and parenchymal cell microenvironmental interactions control the osteoclast differentiation pathway. Forkhead box or FOXO transcription factors help protect against the effects of OS by preventing excess accumulation of reactive oxygen species and removing damaged and abnormal cells via apoptosis. Interleukins, tumor necrosing factor, transforming growth factor beta, prostaglandin E2, and hormones interact to osteoclasts. Receptor activator of nuclear factor Kb ligand, we'll call it RANKL, and its receptor RANK and its decoy receptor, osteoprotegrin or OPG, maintain bone homeostasis. RANKL is a member of the TNF or tumor necrosing factor family and is expressed by osteoblasts and their immature precursors and is necessary for osteoclast development. RANKL activates the RANK receptors, which is expressed on osteoclasts and helps to suppress apoptosis, prolonging osteoclast survival. The osteoprotegrin blocks effects of RANKL and prevents it from binding and activating RANK. Cytokines and hormones regulate the balance between RANKL and OPG. Postmenopausal women have higher levels of rankle on bone marrow stromal cells, T cells, and B cells. Rankle is increased when estrogen levels are decreased, leading to the increased formation of osteoclasts while reducing osteoclast apoptosis. Now let's talk about some risk factors. Some risk factors for osteoporosis include women age 65 and older, men age 70 and older, anyone over the age of 50 who has had a fracture or other related risk factor, women going through menopause who have low body weight, prior fracture from a fall from a standing position or lower, and or are on high-risk medications. In addition to these, Caucasian and Asian women are at the highest risk after going through menopause. Men with low testosterone are also at an increased risk due to the factor testosterone plays in maintaining strong bones. Smokers and drinkers also have increased risk, as well as those with a sedentary lifestyle. People with kidney failure, inflammatory bowel disease, rheumatoid arthritis, liver disease, or an eating disorder are also at increased risk. So, picture yourself as the primary care provider for a 70-year-old Caucasian female patient who presents to your clinic. She comes in with her daughter for her yearly check-in and is in relatively good health. She lives alone, and her daughter voices her concerns about constantly worrying about her falling and being hurt when she's away. How can we evaluate this patient and provide insight to help prevent any injuries? We can start with a pertinent history that includes questions that involve any previous fractures, falls, diet and exercise history, specifically weight-bearing exercises, and we can assess for any noticeable deformities in her stature. Fractures to the vertebral column cause kyphosis and diminished height. Fractures to the femur, humerus, distal radius, and ribs are also common. Femoral neck fractures, for what most people call hip fractures, can be quite serious due to their resultant chronic pain, disability, diminished quality of life, and premature death. Subsequent sequelae from hip fractures can include fat embolisms or pulmonary embolisms, hemorrhage, or shock. One place we can start with this patient is by recommending a dual X-ray absorptiometry, or a DEXA scan. This is the current examination of choice for diagnosis. However, it should be noted that DEXA scans do not provide information about bone strength or fracture risk. The DEXA scan will give us a T-score. A score of negative 2.5 can indicate osteoporosis. The WHO has presented the Fracture Risk Assessment, or FRAX, to evaluate for fracture risk. This can help estimate patients' 10-year fracture risk. Other lab values we can evaluate can include serum calcium, phosphorus, and alkaline phosphate levels. Your patient asks, well, should I just take more calcium supplements? Interestingly enough, the science does not back this up. While the calcium intake for young women should be about 1,000 milligrams daily and 1,500 milligrams per day in postmenopausal women, primarily from dietary sources, it has been suggested that additional calcium and vitamin D do not prevent primary fracture risk and can increase the chance of renal stones. Instead, we can counsel our patients to maintain healthy calcium levels from cheese, yogurts, and fruits and vegetables. Other medication options can include biphosphonates like alendronate and risendronate. These meds are chosen due to their efficacy, favorable costs, and the availability of long-term safety data. Raloxifene is a selective androgen receptor modulator that inhibits bone reabsorption and reduces vertebral fracture risk. This medication can also increase the risk of thrombolytic events and hot flashes, so keep that in mind. If patients cannot tolerate oral biphosphonates, zoledronic acid can be a useful option given via injection. Denosumab is also a promising medication for the treatment of osteoporosis as it binds and inhibits the RANKL, blocking the maturation, function, and survival of osteoclasts, thus reducing bone reabsorption. This medication is fairly pricey though. As we can see, many things can contribute to the development of osteoporosis across a patient's lifespan, culminating in an increased risk for their risk of fracture. Osteoporosis has no clinical manifestations often until there is a fracture. Fractures cause significant morbidity, and in men in particular, they can cause mortality. Osteoporosis is preventable and treatable, but because there are no warning signs before a fracture, many people are not being diagnosed in time to receive effective therapy during the early phases of the disease. Several interventions, including an adequate intake of dietary calcium and vitamin D, are fundamental aspects for any osteoporosis prevention or treatment program. This includes lifelong regular weight-bearing and muscle strengthening exercises, cessation of tobacco, and diminishing the use of alcohol. Thank you so much for joining me today. I hope you learned something, and I hope you go off into the future and are able to identify patients at risk for osteoporosis and provide the best future they can possibly have. Thank you.